Dear colleagues, thank you for taking time to watch this short clip on some of the basic aspects in the diagnosis of an underlying autoimmune disease, often referred to as connective tissue disease. The connective tissue diseases include autoimmune diseases such as rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis, autoimmune myositis, the ANCA-associated vasculitis syndromes, mixed connective tissue disease, and undifferentiated connective tissue disease. I will be focusing on the ANA test with reference to cytoplasmic antibodies, the CTD ENA screen, and the double-stranded DNA test. I will also make brief mention of specific immunoblots, also referred to as line immunoassays. ANA stands for anti-nuclear antibody and is the test that is used to facilitate the diagnosis of SLE and related conditions. Given its very high association with SLE, a negative test is also useful in excluding the diagnosis of SLE. The ANA test is, however, commonly requested when patients have vague symptoms that include musculoskeletal symptoms and fatigue. Different ANA screening tests are available with associated pros and cons. These include immunofluorescence assays and solid phase assays such as ELISA test or immunoblots. The ANA test used at AMPATH is the reference method of choice and is an indirect immunofluorescence test using the human epidermoid carcinoma cell line, also known as the HEP2 cell line. This cell line is particularly useful for ANA testing due to large nuclei and the fact that it contains most of the autoantigens. The ANA test involves incubating patient serum with HEP2 cell substrate, washing off unbound antibody and proteins, and adding fluorescein-labeled anti-human IgG conjugate. The slides are read using UV light. Newer automated platforms employ different stains and photograph the slides, which are then subsequently evaluated for ANA. The ideal ANA screening titer remains controversial. A large multi-center study in the 1990s revealed that a screening titer of 1 in 40 is the most sensitive to diagnose SLE and related conditions. This is offset, however, by the large number of healthy individuals with low titer ANA. In South Africa, most laboratories screen at 1 in 80, which is a compromise to assist in reducing false positive results. Ideally, a normal range needs to be established for our population. ANA patterns include nuclear, mitotic, and cytoplasmic patterns. I would like to refer you to ICAP, the International Consensus of ANA Patterns, at www.anapatterns.org. Their aim is to standardize reporting of ANA. The website includes all ANA patterns with disease associations. Please note that more than one ANA pattern may be identified. It is up to each laboratory to evaluate their competency in identifying patterns. At AMPATH, we report the nuclear and mitotic patterns and report the presence of cytoplasmic antibodies without further characterization. It is important to note that funders in South Africa do not recognize cytoplasmic antibodies as part of the ANA test, and this should be requested separately. Cytoplasmic antibodies may be present in patients with primary biliary cholangitis, autoimmune myositis, and SLE. Cytoplasmic antibodies at titers below 1 in 80 may very well be clinically significant. This is a potential problem as we screen at 1 in 80. We thus currently recommend the cytoplasmic immunoblot as the test of choice. ANA patterns are only loosely associated with an underlying autoimmune disorder. Examples include the centromere pattern in the CREST syndrome or limited scleroderma, nucleolar or speckled patterns in systemic sclerosis, speckled pattern in mixed connective tissue disease, homogeneous or speckled or nucleolar patterns in SLE, and speckled or homogeneous pattern in Sjogren's syndrome. The greater the pretest probability of an autoimmune disease, the more likely that the ANA will assist in the diagnosis of the condition. The ANA test is considered very useful in the diagnosis of SLE, systemic sclerosis, and Sjogren's syndrome when signs and symptoms attributable to the disease are present. For example, in SLE, if there is evidence of photosensitivity, rash, ulcers, pleurisy, etc. In systemic sclerosis, the presence of Raynaud's phenomenon or skin changes, and in Sjogren's syndrome, dry eyes and mouth. The ANA test is only moderately useful in patients with autoimmune myositis. In general, a positive ANA test is associated with systemic autoimmune disease and organ-specific autoimmune disease. ANA positivity is also noted with greater frequency with certain viral infections such as EBV, HIV, hepatitis C, parvovirus B19, and bacterial infections such as subacute bacterial endocarditis and syphilis, in lymphoproliferative disease, paraneoplastic syndromes, and miscellaneous conditions such as inflammatory bowel disease and interstitial pulmonary fibrosis. It is therefore prudent to consider these causes of a positive ANA test. The ANA test may also be positive in patients who have first-degree relatives with autoimmune disease and with the use of certain medications, this then in the absence of drug-induced autoimmune disease. It is also known that patients may have a positive ANA test for decades before developing an autoimmune disease. As previously mentioned, healthy subjects may have a positive ANA test, but usually at lower titers. If an ANA-associated autoimmune disease has been confirmed, further testing of the ANA titer is not recommended as it doesn't correlate with disease activity. Other tests are available, example the anti-double-stranded DNA to determine disease activity in SLE. The advantages of the immunofluorescent test are that it can identify a very broad range of autoantibodies. However, it should be noted that Rho60, also known as SSA or Rho, and ribosomal P protein may be lost during processing. This may thus result in a false negative ANA screen in patients with Sjogren's syndrome and in patients with SLE where Rho or ribosomal P protein are the only autoantigens. The disadvantages of the indirect immunofluorescence tests are the labor intensity and specialization that is required, and the fact that the ANA patterns are not disease-specific. So what are the alternative ANA tests? These are what are termed the solid phase assays, where specific antigens are immobilized to a surface and the serum is tested for corresponding autoantibody. These assays are mainly ELISA tests, fluorescent enzyme immunoassays, and immunoblots. The CTD, or connective tissue disease test, is a well-known alternative used by most laboratories. The CTD screening assay detects antibodies to RNP, Smith, Rho, LAR, SCLER70, JO1, centromere B, PM-SCLER, MI2, fibrillarin, PCNA, ribosomal P protein, double-stranded DNA, RNA polymerase 3, and Rho52. Please note the term ENA, which stands for extractable nuclear antigens, is a relic term that refers specifically to the water-soluble antigens RNP, SM, Rho, and LAR. The current CTD screen is an extension of the ENA screen. The term ENA is still used interchangeably with CTD. The solid phase assays are very useful for high-throughput automated laboratories and for semi-quantification of results, but there is a concern regarding their lack of sensitivity compared to the indirect immunofluorescence test. The solid phase assays include fewer antigens than the Hep2 cell substrate. Because of this, the American College of Rheumatology has recommended that the ANA indirect immunofluorescence test should remain the initial ANA test. A positive ANA indirect immunofluorescence test is also part of the diagnostic criteria for SLE, drug-induced lupus, mixed connective tissue disease, and autoimmune hepatitis. Because ANA patterns are not disease-specific, further testing for disease-associated autoantibodies needs to be done. Other reasons that underscore additional testing include the fact that cases of SLE and related disorders may have ANA titers below 1 in 80, and some connective tissue diseases have no ANA but rather cytoplasmic antibodies. We thus recommend that when the ANA test is ordered, that a request for a CTD ANA screen is included. This will help identify if a patient has a specific autoantibody target, which can help with early diagnosis and treatment and improved outcomes for patients with autoimmune disease. The screen can be requested on its own or requested to be broken down to the different autoantigens. We currently resolve positive CTD ANA screens using our CTD immunoblot. The immunoblot identifies the antigens in the screening assay, but not antibodies to MI2 and fibrillarin. The immunoblot additionally identifies antibodies to nucleosome, histone, antimitochondrial antibody M2, and dense fine speckled 70, which are not represented in the screen. The anti-double-stranded DNA on the immunoblot has been found to give unreliable results and is not reported. It is thus essential that a double-stranded DNA test must be requested separately. We offer a SLE-specific double-stranded DNA test where the double-stranded DNA is coupled with nucleosome to the solid phase to reduce non-specific reactions. Please note that standardization of autoimmune tests has been in the pipeline for many years but has not been realized. This is largely due to competition and intellectual property rights in the research and development space. It is thus a reality that results for autoimmune tests often differ between test platforms, which understandably causes confusion. This is particularly important when comparing results between different service providers. Although we have embraced the use of immunoblot profiles, individual autoantibodies, example anti-SSA, anti-Smith, anti-JO1, etc., can be individually requested for those with a more targeted approach. The advantages of the immunoblots are that they are billed with a single cost code whilst testing for a large number of autoantibodies, resulting in comprehensive reporting at a reasonable cost to the patient. In some instances, the immunoblots have replaced older technology. Example, the autoimmune liver blot and cytoplasmic blot have replaced the indirect fluorescent antibody test. Immunoblots that are available and are relevant to this topic include the CTD ANA immunoblot that identifies 16 autoantibodies, the autoimmune myositis immunoblot that identifies 16 autoantibodies, the systemic sclerosis immunoblot that identifies 13 autoantibodies, and the cytoplasmic immunoblot that identifies 10 autoantibodies. Other immunoblots currently on offer include the autoimmune liver blot, ganglioside, and paraneoplastic immunoblots. Please find attached to this email our autoimmune request form that will assist you in making appropriate test choices for your patients. Thank you.